everyone, today I'm going to give a talk on acetabular fractures. So starting with acetabular anatomy, the acetabula has an anterolateral and inferior inclination. It is 50 to 60 degree angle to the horizontal plane and 25 to 30 degrees to the sagittal plane. It has an 18 to 20 degree anteversion, and your average diameter of the acetabulum is 50 mils. There are two columns, the anterior and the posterior column, which form an inverted Y. The posterior column, which has the ischium and part of the ilium. This column biomechanically transfers your load from your trunk and your spine via the sacroiliac joint and into your proximal thigh. The posterior border is formed by a greater sciatic notch, the ischial spine, the lesser sciatic notch, and the ischial tuberosity. The medial border is formed by the ischium and the posterior parts of the quadrilateral surface. The anterior column is composed of the pubis and part of the ilium. The inner surface represents the anterior parts of the quadrilateral surface and forms the osseous border of the obturator canal. The lunate surface is formed by a narrow anterior horn and a broad posterior horn and an acetabular dome. Beneath these horns is the acetabular fossa, also known as the cotyloid fossa, which forms the central acetabular fall. The fossa contains the pulvinar, the synovial-covered fat pad, and ligamentum teres. So the mechanism of injury for acetabular fractures is caused by the force that drives your femoral head into the pelvis. The type of fracture is therefore dependent on the position of the femoral head at the moment of impact. In elderly patients, this is typically a low energy mechanism from falling from a standing height where they fall into a posterolateral aspect of the hip. This drives the femoral head into the acetabulum with an anteromedial directed force. And they typically have anterior column fractures. In the younger patients, it is typically caused by high energy injuries such as a motor vehicle accident, where the dashboard pushes on the femur and the femoral head drives into the posterior aspect of the acetabulum, typically causing a posterior column fracture. So the clinical presentation, the leg is shortened and externally rotated, and their patients will have associated injuries that need to be excluded based on EMSDP principles, particularly if they've had a motor vehicle accident. These include chest injuries, long bone fractures, spinal fractures, Morel-Lavallée lesions, and we always need to exclude perineal injuries as well. When associated injuries are present, it's always important to consider damage control orthopedics. So the classification of acetabular fractures, the most common classification, is the Judet and the Luteinal classification. It is composed of 5 elementary fractures and 5 associated fractures. The 5 elementary fractures are the posterior wall, the posterior column, the anterior wall and the anterior column, and transverse fractures. A wall fracture is defined as a partially articular fracture which is characterized by a fracture of the acetabular joint surface without involvement of the entire column. The associated fractures include the posterior column and posterior wall, the transverse and posterior wall, T-type, anterior column wall, posterior hemitransverse, and then both column fractures. One of the issues with the Judet and Luteinal classification is there is some overlap between the different types, including the localization of the T component can be highly variable. To distinguish between a T-type and associated transverse posterior wall fracture, it is best to decipher this based on its position to the ischial groove. If the posterior fracture extension is below the ischial groove, then it's a T-type fracture. If it's above the ischial groove, then it's an associated transverse posterior wall fracture. The other classification that exists for acetabular fractures is your AO classification. This does incorporate the Luteinal classification. There are 3 types, type A being partial articular, what involves one column, type B has partial articular involving a transverse component, and then type C involves both your columns. Each of these types is then further subdivided into subgroups based on a comminution of the fracture. There are then further additional modifiers integrated into the system to describe the main fracture with more characteristics, including the number of articulating fragments, the extent of joint displacement, if there is an accompanying femoral head injury or an acetabular injury that involves the cartilage, a shear injury or marginal impaction, and intra-articular fragments that require surgical approval. One of the biggest issues with the AO classification is that because of all the subgroups and modifiers, you end up with 20,000 different classification possibilities. So looking into the radiological evaluation of acetabular fractures, you should always have a pelvic AP X-ray, a hip AP, and Judet views, which include your iliac oblique view and your obturator oblique view. A CT is gold standard and ideally should be done in 1 to 2 mm sections. On the AP pelvis X-ray view, it is important to know 6 radiological lines for evaluation of acetabular fractures. So the first is the iliopectinal line. This is the line from the pubic symphysis to the sacroiliac joint, and a disruption in this line represents an anterior column fracture. The ilioischial line starts at the lateral border of the obturator foramen, overlaps the acetabular teardrop, and ends at your sacroiliac joint. It represents a posterior column fracture in its medial and inferior parts. The posterior wall line is the most lateral part of the hip joint on AP view, but depending on the amount of retroversion in patients, the posterior wall line can overlap the anterior wall line called the crossing sign. The anterior wall line is a double-shaped line medial to the posterior wall line. It includes your anterior and superior margin of the obturator foramen and is really only visible on high-quality X-rays. The acetabular roof line is a line over the acetabular dome, and in disruption in this line represents injury to the superior weight-bearing area. And lastly, the teardrop line is a U-shaped line that's formed by an end-on projection of the bony ridge along the floor of the acetabular fossa. It corresponds to the lateral acetabular fossa and the quadrilateral surface. So Judet views are 2 oblique views that are taken with the pelvis tilted at 45 degrees. The importance of the views is that the iliac oblique view allows you to appropriately visualize the iliac fossa, the posterior column, and the anterior wall. The obturator oblique view allows you to visualize the obturator foramen, the anterior column, and the posterior wall. The roof arc angle is an angle that's measured on AP, obturator, and iliac oblique views, and it gives you a radiological indication of whether you have a stable or unstable fracture. To measure the roof arc angle, you take a vertical line through the femoral head and a line through the fracture, and the angle, if it's less than 45 degrees, is considered unstable because the fracture involved the weight-bearing dome of the acetabulum. Other important signs on X-ray include the spur sign, which is visualized on the obturator oblique view. It occurs when part of the iliac bone is attached to the sacroiliac joint and is displaced medially into the pelvis. This is indicative of a both column fracture. The gull sign is visualized on the iliac oblique view and is a sign of impaction of the superior medial roof, which will indicate a high pressure load to the anterior medial joint surface and the quadrilateral surface. It is pathognomonic for posterior wall fractures. It is named after the bird itself. So typically your most common fracture patterns in your younger patient are posterior wall transverse fractures, and your elderly patients typically get your anterior column or both column fractures. So this is an algorithm which I found really useful to determine what lines are visible on the pelvic radiographs that are disrupted, which indicate the type of fracture the patient has anatomically. So moving on to the treatment. The non-operative treatment for acetabular fractures is typically non-weight bearing or touch weight bearing for 6 to 8 weeks. This is dependent on the characteristics of the fracture, including a less than 2 mm articular step. If it's a weight bearing acetabular roof is intact, and that's based on your roof arc angle of greater than 45 degrees. If the femoral head is congruent out of traction and less than 20% of the posterior wall is affected. Both column fractures also have to have excellent secondary congruence to be managed non-operatively. Important patient factors are high operative risk, such as elderly patients with significant comorbidities, late presentations greater than 3 weeks, and severe osteoporosis, as it greatly affects the rigidity of the fixation. It is also important in elderly patients to consider that they can be like a neck of femur fracture, and managing their pain and pressure sores can be difficult. So operative management is indicated when you have an incongruent reduction and fracture through the unstable weight-bearing dome. More than 20% of the posterior wall is involved. If you fail to do a closed reduction after hip dislocation, or if you have intra-articular loose bodies. If the fracture is less than 3 weeks and the patient is physiologically stable and has an adequate soft tissue envelope, it is important to consider operative management. So the goal for surgical management is the anatomical reconstruction of the joint surface and stabilization of the main weight-bearing area of the acetabulum. To fix acetabular fractures, you've got to consider if it's a column or wall fracture, the amount of displacement, if there's marginal impaction, or associated injuries. The guideline is that a column fixation technique should be done using bridge platelet screws or percutaneous column screws. A wall fixation technique should be done using bridge plate and screws, lag screws, or buttressing plate. So this is an algorithm that determines, based on the radiological and patient characteristics, whether a patient should have an operation or not. So there are 4 surgical approaches that can be undertaken for acetabular fractures that include the kacher-Langenbeck, the llioinguinal, the modified Stoppa, and extended iliofemoral. The decision to make on which approach to do is mainly based on the location of the fracture site. So a kacher-Langenbeck is a posterior approach which should typically be done for posterior column and wall fractures or most transverse and T-shaped fractures. The llioinguinal is an anterior approach which is typically done for anterior column or wall fractures, and then the modified Stoppa is your more modern day operation using the anterior approach, and is beneficial because it gives you a greater variety of fractures to fix through this one approach, including your pubic body, your anterior fractures, medial aspect of the posterior column fracture, and anterior sacroiliac joint fractures. The extended iliofemoral is essentially the Smith-Peterson approach, which is extended over the iliac crest and is used for transverse and both column fractures. This approach, however, is less commonly done these days. So the kacher-Langenbeck approach allows a direct visualization of the entire posterior column and part of the supraacetabular region. It also can allow palpation of your quadrilateral surface if you want to check a reduction. It is contraindicated in anterior column wall fractures, and this can be performed in either the prone or the lateral position, but the lateral position is preferred. So the skin incision starts just anterior, posterior, superior iliac spine is directed to the tip of the GT and down your femoral axis. The superficial dissection involves the iliotibial band distally and your gluteus maximus proximally. The deep dissection involves part of the gluteus maximus divided and gluteus medius elevated from the ilium. You will then expose the short external rotators. It is important in this approach to transect the short external rotators 1 centimeter away from their insertion because you need to ensure you protect the blood supply to the femoral head. You also need to identify the sciatic nerve and release tension by keeping the hip extended and knee flexed throughout the operation. It is also crucial to protect the deep branch of the medial circumflex femoral artery at your upper border of the quadratus femoris because this is the main supply to the femoral head. Disruption of this branch can lead to osteonecrosis of the femoral head. The abductors and the soft tissue are then cleared to visualize the posterior capsule and the posterior wall, and the capsulotomy can be performed. Dissection can also be extended to the superior acetabular area by blunt dissection of gluteus maximus and minimus from your superior capsule and supraacetabular periosteum. One of the advantages of the kacher-Langenbeck approach is that you can enlarge the approach to visualize the superior intraarticular and the anterior regions of the acetabulum by performing a trochanteric flip osteotomy, which can either be done as a straight or a Z-shaped osteotomy. Surgical hip dislocation with a trochanteric flip osteotomy can also give you an entire view of the hip joint. So moving to the llioinguinal approach, which is an anterior approach, allows visualization of the iliac fossa, your innominate line from the pubic symphysis to the sacroiliac joint and the quadrilateral surface. It is contraindicated in posterior column and wall fractures or fractures with posterior marginal impactions. The skin incision starts slightly posterior to the apex of the iliac crest. It lunges along the iliac crest, turns anterior at the anterior superior iliac spine, in line with the inguinal ligament, and up to the pubic symphysis. The surgical dissection medially involves the external oblique aponeurosis and rectus sheath being divided. On the lateral side, you incise the periosteum along the iliac crest. You elevate iliacus from the iliac fossa to expose the sacroiliac joint and the pelvic rim. The inguinal ligament is then divided, which will expose the lateral femoral cutaneous nerve on the lateral edge and the spermatic cord or the round ligament on the medial edge. The deep dissection involves the internal oblique and transverse abdominis detaching from the posterior wall of the inguinal canal. The inferior epigastric artery is exposed and needs to be protected. You then dissect between the symphysis pubis and the bladder. The periosteum is then pushed upwards to expose your femoral vessels, the nerve, and iliopsoas, which all need to be protected. The subperiosteal dissection is used to expose your pelvic brim, your rami, and the quadrilateral surface. So you then end up with 3 windows in the llioinguinal approach, which you use to reduce and fix your fracture site. So the 3 windows include your medial window, which is medial to the femoral artery and vein. It gives access to the superior pubic ramus and symphysis. The middle window between the femoral artery and iliopsoas, which gives access to the quadrilateral plate, and then your lateral window, which is lateral to iliopsoas, which gives access to the inner surface of the ilium all the way to the anterior aspect of the sacroiliac joint. One of the important things to be aware of in the llioinguinal approach is the corona mortis. It is a retropubic vascular anastomosis between your obturator vessels and your inferior epigastric vessels, or between the external iliac vessels. The reason it's important is because if you tear one of these vessels, it is very difficult to control the bleeding. So moving on to the modified Stoppa approach. This is your modern day anterior approach, which is most commonly done. It is an anterior intrapelvic but extraperitoneal approach. It is contraindicated if you have posterior only fractures that exit below the ischial spine. So the skin incision is a fan steel incision, which is made 1 to 2 centimeters superior to the pubic symphysis. It is very similar to the incision used by general surgeons to perform hernia operations. The surgical dissection then involves the rectus fascia split longitudinally, and transversalis fascia is incised just superior to the pubic symphysis. The deep dissection involves the blunt dissection of the reticular space between your symphysis and the bladder, subperiosteal dissection along the pubis, the superior pubic ramus, posterior surface of the ramus, and the pelvic brim up to your internal iliac fossa. The iliopectoral fascia is then released to enter your true pelvis. You then retract and you protect your external iliac vessels, and one of the advantages of this approach is that you are dissecting underneath the external iliac vessels instead of the llioinguinal approach where you dissect in between. But you still have to be very cautious of the corona mortis in this approach as well. It is important that you ligate and clip the vessels in advance to allow you to dissect further along the pelvic brim and the quadrilateral surface. Subperiosteal elevation of the iliopsoas is then performed, which shows your entire pelvic brim. The advantage of the modified Stoppa approach is that you can increase the exposure through a lateral window. This is equivalent to the lateral window of the llioinguinal approach, but is made through a separate incision. So where the external oblique is released and iliacis muscle is elevated subperiosteally to expose the iliac fossa and the anterior aspect of the sacroiliac joint. So the advantage of the modified Stoppa in comparison to the llioinguinal approach is that you avoid having a middle window. This means you have minimal dissection of the llioinguinal canal, the femoral nerve, the external iliac vessels, and the spermatic cord. So it is a less invasive operation. It's important when you're considering operative management of acetabular fractures in the elderly that you consider the role of a total hip replacement. The main indication for primary total hip replacement in elderly patients is if there is a fracture that involves comminution at the superior medial acetabular dome involving the weight-bearing area, and if you have concomitant femoral head injury which affects the femoral cartilage, or in patients that have previous symptomatic osteoarthritis. Posterior column must be sufficiently stable to allow for prosthesis insertion, and this may require fixation of the anterior column to the posterior column to allow a stable cut fixation and to ensure adequate weight bearing. The kacher-Langenbeck approach is ideal for this, particularly if you need to fix the posterior column and do a primary total hip replacement. Any bony defects should be managed with bone grafts and trabecular metal implants. The indication for secondary total hip replacement is post-traumatic osteoarthritis or femoral head avascular necrosis. Post-traumatic osteoarthritis after an ORIF can range between 6 to 31% in the elderly patients. The risk factors for developing arthritis include superior medial acetabular impactions, involvement of the quadrilateral surface, femoral head cartilage damage, marginal impaction or comminution of the posterior wall, and a posterior hip dislocation. So this is an image of one of Mr. Clifford's patients at the Royal Melbourne who has an acetabular fracture and associated subcapital femur fracture and underwent both fixation of the acetabulum and a primary total hip replacement in the acute setting. And as you can see from the postoperative x-ray, it looks pretty amazing. So complications that can occur from acetabular fractures include post-traumatic osteoarthritis, which has, given that patients are typically younger patients and survival at 20 years is 80% post an acetabular horror. Femoral head avascular necrosis, DVTs and PEs, bleeding, infections, and heterotopic ossification. This is most common in an extended iliofemoral approach, but can also occur in llioinguinal and a modified Stoppa approach. It is therefore ideal to give indomethacin for 5 weeks post-operatively. Thank you.